Namaskar. Today we'll study Alzheimer's disease. Alzheimer's disease is a type of dementia. Dementia is loss of memory which may be caused by uh, brain infection, alcohol toxicity, brain trauma, stroke, etc. When it is caused by brain infection, we call it as vascular dementia. But Alzheimer's disease is different from all these, and in Alzheimer's disease, there are some pathological features which were first identified by Dr. Alois Alzheimer in a female patient in 1906, and those features are extracellular deposition of beta amyloid, amyloid beta plaques, intracellular neurofibrillary tangles, hyperphosphorylated tau, and in addition there are other features. And initially this Alzheimer's disease was called as senile or late onset, which is more than 65 years of if the age of the patient is more than 65 years, then it is called senile dementia, and it was usually called as Alzheimer's disease. But later on it was identified that no, both pre-senile before 65 years of age or early onset and senile, in both the cases the features are same. So later on this classification of dementia pre-senile and senile to link to Alzheimer's is no more there. And in Alzheimer's disease there are main two pathological features are the extracellular deposition of beta amyloid called as amyloid beta plaques, and intracellular deposition of hyperphosphorylated tau proteins called neurofibrillary tangles. In addition, there are two neurotransmitters, one is acetylcholine and the other is glutamate. There is deficiency of acetylcholine and there is excess of glutamic acid. In addition to that, there is also neuroinflammation and oxidative stress. So all these five theories that lead to neurotoxicity, loss of cholinergic neuron in hippocampus and basal forebrain. So that leads to Alzheimer's disease. And the symptoms of Alzheimer's disease, it is progressive loss of memory. So there is progressive loss of memory, and there is also dysfunction of the cognition. We call it as cognitive dysfunction. So cognition is nothing but the ability to the process by through which we learn, that is also not functioning properly. So progressive loss of memory along with cognitive dysfunction, this leads to loss of short-term memory initially, and then it leads to loss of long-term memory, and later on there will be reduced verbal fluency and impairment of speech due to failure of arranging words in proper sequence, and slowly there will be progression of brain degeneration, and it will lead to many symptoms, and the most common symptom is the difficulty in swallowing, because the area of brain which deals with swallowing is also degenerated, so there will be difficulty in swallowing. So the patient inhales food particles, gastric fluids, liquids, and that leads to aspiration pneumonia, and the patient dies because of aspiration pneumonia. So majority of AD patients in their latter stages of life suffer from pneumonia, and this is the reason. Then we'll discuss the theories which are associated with Alzheimer's disease, and those theories already we just said that these are the five theories. One is amyloid beta plaques, second is hyperphosphorylated tau, third is acetylcholine deficiency, fourth is glutamate excitotoxicity, fifth is neuroinflammation and oxidative stress. So let us discuss them, and there is one protein called amyloid precursor protein, from which amyloid beta is formed. So amyloid precursor protein is the protein to which three enzymes can act. One is alpha secretase, beta secretase, and gamma secretase. And this alpha secretase, when it acts, the amyloid precursor protein is degraded to soluble amyloid precursor protein, which has trophic functions or growth factor functions. But when beta secretase and gamma secretase act, we get amyloid beta 40 or 42. So these amyloid beta proteins, they are usually produced in small amounts and get cleared. But when there is mutation in the ApoE4 gene, then there will be no clearance of amyloid beta and increased production of amyloid beta is there. And in case of mutation of amyloid precursor protein or presenilin gene, there is increased gamma secretase action, which leads to increased amyloid beta 42, and this amyloid beta 42 has higher tendency to bind with amyloid beta 40. So amyloid beta 42 and amyloid beta 40 together form amyloid beta plaques, which are deposited extracellularly, and these amyloid beta plaques can activate the kinases, can cause oxidative stress, mitochondrial dysfunction, inflammation, which ultimately lead to neurotoxicity. And by activating the kinases, these kinases phosphorylate tau. Tau is usually has regulatory functions in the neurons, and tau protein promotes the tubulin assembly, stabilize microtubules, and has normal functioning of the neurons. But because of the kinases activated by amyloid beta plaques, there will be hyperphosphorylation of the tau protein, and these hyperphosphorylated tau form paired helical filaments, which cause the intracellular deposit of neurofibrillary tangles. So amyloid beta plaques and neurofibrillary tangles are the two characteristic features in the pathology of Alzheimer's disease. Then the amyloid beta plaques also increase the acetylcholinesterase activity, thereby decreasing the cholinergic function, decreasing the level of acetylcholine in the brain. They also increase the glutamate excitotoxicity. So all these leads to the neurodegeneration in the hippocampus and basal forebrain. The cholinergic neurons are destroyed, and there will be Alzheimer's disease. So the drugs, how we can use the drugs? We can use drugs which can inhibit acetylcholinesterase. As you know, acetylcholinesterase is the enzyme which degrades acetylcholine to choline and acetic acid, and by inhibiting this enzyme, you can increase the level of acetylcholine. So most of the FDA approved drugs belong to this category. We can also decrease the glutamate excitotoxicity, and one drug, memantine, is there, FDA approved. We can target the amyloid beta plaques, we can target the hyperphosphorylated tau, and we can also target the inflammation and oxidative stress by using anti-inflammatory drugs and antioxidants. Okay, so you can see this picture actually describes total the pathogenesis of Alzheimer's disease. So the drugs for AD, number one, drugs which increase acetylcholine response by inhibiting acetylcholinesterase. 4 drugs are there which are FDA approved: tacrine, rivastigmine, donepezil, and galantamine. We can also use the nicotinic acetylcholine receptor agonist, which is a ligand-gated ion channel linked to calcium channel, and alpha 7 nicotinic acetylcholine receptor agonist. 2 drugs are there, N-seniclin and galantamine. Galantamine, in addition to inhibiting acetylcholinesterase, can also act as agonist on the nicotinic cholinergic receptor. Another group of drugs which are now under trial, that is H3 receptor antagonist. H3 is histamine 3 receptor which is located presynaptically in the cholinergic nerve endings, and histamine when binds to H3 receptor it inhibits the release of acetylcholine. So it is a heteroreceptor located presynaptic cholinergic neurons, and histamine inhibits acetylcholine release. So histamine receptor antagonist, H3 receptor antagonist will increase the acetylcholine release, so increase the cholinergic function. So the code name of the drug is DL77. So it is not yet developed and not yet it has come to the market. So second group of drug is the drugs which decrease the glutamate response. So glutamate acts on the NMDA receptor, N-methyl D-aspartate receptor, and glutamate we can either inhibit the glutamate release from the presynaptic glutamate release inhibition, and the drug is riluzole, or we can use NMDA receptor antagonist memantine. Memantine is FDA approved drug. Then we can target the amyloid beta plex, the first group of drug, by increasing the clearance of amyloid beta using monoclonal antibodies, and some of these monoclonal antibodies are now approved by FDA, like lecanemab, and some examples of these monoclonal antibodies are there: crenizumab, aducanumab, bapineuzumab, solanezumab, gantenerumab, and lecanemab. We can decrease the production of amyloid beta by inhibiting either gamma secretase or beta secretase. The beta secretase inhibitors are not yet come to the market, so code names are there, and two drugs can inhibit gamma secretase, that is semaglutide and avagalstat. Third group of drug targeting amyloid beta plex are the granulocyte macrophage colon stimulating factor like sargramostim, which increase the microglial phagocytosis of amyloid beta in addition to some anti-inflammatory action. And the fourth group under development are the vaccines targeting amyloid beta plex. Then the fourth group of drugs which decrease the hyperphosphorylated tau by inhibiting the tau aggregation, by stabilizing the tau, and recent developments are some of the vaccines. So tau aggregation inhibitors like curcumin, the natural drug curcumin, oleocanthal, tau stabilizers like ipothiolone D, and this is a code name of a newly drug under development. And some of the vaccines under development are ADVAC1, ACI35. Then many drugs which are now clinically used are repurposed for use against Alzheimer's disease, and one target is the renin-angiotensin system. And renin-angiotensin system, let us just recall it, angiotensinogen, which is an inert peptide released from liver, and when renin acts on it, it is converted to a decapeptide angiotensin 1. Renin is released from the kidney. Angiotensin converting enzyme is released from the lungs. So this ACE converts angiotensin 1 to angiotensin 2, which is an octapeptide, and this angiotensin 2 acts either on AT1 receptor and AT2 receptor. When it acts on AT1 receptor, it causes neurotoxicity, and when it acts on AT2 receptor, it is neuroprotective, opposite action. So AT2 receptor action is increasing learning and memory. AT1 receptor action is neurotoxicity causing Alzheimer's disease. So AT1 receptor mediated angiotensin 2 actions are oxidative stress, neuroinflammation, some of the vascular diseases, and there is also increased formation of amyloid beta plex, all these causing Alzheimer's disease. So either we can block this pathway, or we can stimulate this one. So 82 receptor agonist we can use, which are under development, and 81 receptor blockers or ACE inhibitors can be used. 81 receptor blockers like andesertan, telmisartan, irbesartan are under development, and the ACE inhibitors like captopril, perindopril are under development for use against AD. Then the second group of drugs which are now under research are the anti-diabetic drugs, which are repurposed for use against Alzheimer's disease, because hyperglycemia can also cause neurodegeneration. And hyperglycemia causes inflammation, hyperglycemia causes oxidative stress, hyperglycemia produces advanced glycation end products, hyperglycemia dysregulates the lipid metabolism. So the inflammatory mediators like interleukins, chemonecrosis factor alpha, the reactive oxygen species, the advanced glycation end products, the free fatty acids, all cause neuronal insulin resistance, and they impair the glucose metabolism, all lead to increased amyloid beta pathology and increased tau pathology, causing neurodegeneration. And many of the anti-diabetic drugs, including nasal insulin, insulin sensitizers like biguanides like metformin, thiazolidinediones like rosiglitazone, pioglitazone, insulin releasers like sulfonylureas, for example glimepiride, incretin mimetics, which indirectly increase the insulin activity, like GLP-1 agonist exenatide, DPP-4 inhibitors vildagliptin. So all these anti-diabetic drugs are nowadays repurposed for use against Alzheimer's disease. For the role of incretins, you can refer to our earlier videos on incretin mimetics related to diabetes. Then some of the anti-inflammatory drugs are also nowadays repurposed for use against Alzheimer's disease. And first group is non-steroidal anti-inflammatory drugs, which are, we can say, COX inhibitors, cyclooxygenase inhibitors like ibuprofen, indomethacin, and recently one single enantiomer of racemate flurbiprofen, that is tarenflurbil, is under development. Then drugs which can inhibit the release of inflammatory cytokines like chemonecrosis factor alpha, thalidomide, the drug which was withdrawn from the market because of phocomelia, are now under focus for Alzheimer's disease. Thalidomide, it can inhibit the release of cytokines. And sargramostim, already we have discussed. Sargramostim also can decrease the generation of pro-inflammatory cytokines. And now some of the calcium channel blockers like verapamil are also showing anti-inflammatory functions and are repurposed against Alzheimer's disease. So the antioxidants and neuroprotectives like some vitamins, including vitamin E, minerals like selenium, omega-3 unsaturated fatty acids or fish oils, nutraceuticals like lycopene, capsaicin, camel milk have some use in Alzheimer's disease because of their antioxidant and neuroprotective actions. So this is all about Alzheimer's disease and its treatment. Thank you.